is real personalized therapy. You know that the phage works well with the antibiotic, and they both work well to combat that bacteria.
For this part of our interview on bacteriophage therapy for UTI, I'm joined by Dr. Sabrina Green, Dr. Saima Aslam, and Dr. Austen Terwilliger, who collaborate in the area of bacteriophage research. You can find further information and links for each of our experts in the description below. And now we're going to jump into some questions about how phage therapy itself works. And the first question from our audience is, how can phage therapy be delivered?
Okay, well, I'm happy to answer that. So bacteriophages can be delivered in many different ways, and part of that would depend on where the infection is. So in our practice and worldwide also, phages have been used topically, meaning just sort of applied onto burn wounds, for example, or other infected wounds. It can be given intravenously, and we've done that. And Baylor and UCSD both have sort of collaborated on many patients like that. Also nebulized. So for patients with CF or other pulmonary infections, we've given phage just for them to breathe in, so using a nebulizer device. And then when we talk about urinary tract infections, we can use intravenous phage, but also it can be instilled sort of directly within the bladder as well, using a catheter. So I think there are the different ways of doing this. Part of it would really depend on the kind of infection we're treating. That would help make sort of a personalized plan for a patient.
If the infection is not in the bladder, but it's in the ureters or the kidneys, would that also be done by instillation or a different delivery method?
So usually, when you have a kidney infection, it's considered to be a systemic infection, so it's not localized to the bladder. Usually in such instances, I would use intravenous phage because we know that it will get into the kidney sort of tissue very well. And from there, it can easily go down to the ureters as well as the bladder. Generally, bladder instillation has been used for more localized infections that are generally within the bladder. It may be that we could do just bladder instillation for a kidney infection, but personally, I think we should be using intravenous because that usually is a more widespread and systemic infection.
If the phages are delivered to the bladder, will they likely travel around to the rest of the body, or do they stay local like you just mentioned?
I think they stay locally. So there isn't, when we talk about clinical sort of information, there isn't that much that's been done sort of looking at the details of where phages are in patients when we treat with urine infections. There's a lot more animal models, and Austen and Sabrina are welcome to jump in. But for animal models, if we're treating, when we give it to them intravenously or systemically, we know that it gets to the kidneys, we know it gets everywhere where we need it to go. Usually bladder installation such setting will stay local. It can go up to the ureters a bit, but you guys are welcome to jump in. I don't think it would get into the kidney that well.
Yeah, I don't think I have much to contribute. It's something that we're still working on here in the lab. We do have models of UTI, mouse models of UTI, but currently we treat them with IV or IP injections, so we don't do bladder instillation of phage. So that question is we still haven't figured that out yet.
Okay.
Yeah, I wouldn't come up with necessarily any hard and fast rules here yet. I will say when other groups have studied this question, if you give an IV dose of phage to mice, about a third to a half of those phage will end up in the bladder pretty quickly, in maybe the 30 minutes.
Okay. When you deliver phage therapy for a UTI, is it usually a single phage type, or is it a cocktail of some sort?
So I think, and I'm going to have others jump in too. So, for me, clinically, we've actually used cocktails of phages as well as single phages, both with success. So I think partly the goal is not so much do we have 3 or 2, but the goal is what organism are we treating and what are the characteristics of the phage that we are using. So, at times you want a combination because one phage perhaps is great at degrading biofilm, for instance, and another may have a really high threshold to developing resistance. So there's no hard and fast rule. I think both can be successful, but it really depends on the characteristics of the phage itself. So I'll let maybe Austen, you want to add into that?
In a perfect world, we could make and build phage cocktails where we know everything about those phages in terms of how they function, how they would interact with other phages and on the host cell or in the environment of the patient as well. If you knew all that, you could really build, I think, an effective phage cocktail knowing those things. We don't always know those things, and we just have to work with the phages that we do have and find and learn from using them.
Right. When you are using phage therapy for a UTI patient or any kind of illness, really, how do you deliver the doses? Is it like a one-off thing or is it over a period of time?
So part of that, again, depends on the kind of infection we're treating and also the concentration of phage that we receive. So most patients that I've treated, and I think what's sort of now commonly accepted, at least for intravenous use, we use phage at a concentration of 10 to the 9th PFU per mil, which is plaque forming units per mil. And so with a high concentration, usually I'll use twice a day. For patients that have cardiac device infections, we treat longer because traditionally those infections are harder to treat, and we treat for 6 to 8 weeks along with antibiotics. For urinary tract infections, I started off treating much longer. So a few years ago, I think it was unclear it still is actually, what is really the ideal duration of therapy. But over the last few years, I've sort of brought that made it shorter and shorter. So most recently, I treated a patient with recurrent urinary tract infections and prostatitis with 2 weeks of phage, and they've done really well. So I think these are some of the questions that clinical trials will try to address. We started off longer because we didn't know any better, but I think we're moving towards shorter durations of therapy, mainly because phage are replicating within the bacteria as long as that bacteria is there. So again, I think this is something we will hopefully know more about over the next few years with some clinical trials.
If the phages continue to replicate as long as the bacteria are there, why do you need additional doses?
And it may be that one dose is enough. So I think part of it is, so far when we treat patients, or at least that I have, and within the United States, we've treated patients that have been very critically ill or have already, failed many forms of therapy and are sort of at their last resort. And in that instance, we have given multiple doses. Part of the issue was we weren't sure what is the correct dose to use or duration. Some of it is cleared. So our immune system will over time clear those phages. Some of it is every time we give an intravenous dose, Austen mentioned a third is in the bladder, but some of it is actually taken up by the liver, by the spleen. So we have mechanisms in our body that, the goal is to get rid of foreign, invaders, you could say. So yes, I think as the phages are cleared, we do, give repeat doses. But again, what is the ideal duration is unclear for a specific infection.
Yeah, I would add on, for the success and failure of phage therapy, there are just too many unknowns right now that we need more good science for. This interaction between the phage and their host and patient is not really well understood or well modeled, right? It's very difficult to try to investigate these kinds of questions in lab prior to going into a patient, but we are trying to build those models now.
We're also trying to actually get that information in patients and clinical trials. So again, currently, I think we're in a very exploratory phase of phage therapy.
Okay, there were a few questions about the immune system response, so that's answered that. But the other questions that we got were do phages build resistance like other organisms do?
They do, but I'm going to see if Sabrina wants to add in there.
Yes, bacteria become resistant to phage just as they become resistant to anything else. The resistant mechanisms are different though, because antibiotics, they work differently than phage. So there are times when actually bacteria may become resistant to an antibiotic, but still be susceptible to a phage. And sometimes actually when you combine phage and antibiotics, they can work better together. And, the bacteria may change to then become susceptible to an antibiotic. So it's a really interesting concept in the lab. But of course, we've actually seen instances of this in patients as well.
Yes, I just wanted to add a little more to that. So, Sabrina said, yes, phages can develop, or bacteria can develop resistance to phages by a variety of mechanisms, but that's not always sort of a bad thing. So we've seen patients that started off with highly drug-resistant organisms, whether, it was an MDR, Pseudomonas, for example. And as I treated the patient, the bacteria did become resistant to the phage, but that resistant mutant was actually less sort of fit. So it was easier to kill off with antibiotics, or I had a chain susceptibility pattern that now I could use an oral antibiotic to take care of it. And then as in the patient, that Sabrina alluded to, so for this patient, the antibiotic susceptibilities did not change, but the bacteria did have changes in, in its sort of genetic markers or resistance markers that made it less fit. So even though the patient still had bacteria detectable, they were no longer symptomatic or ill from it, and we did not need to treat them.
Yeah, that's very interesting for a lot of the patients in our community who do have antimicrobial resistant infections and often wonder if there is a way forward. So that sounds quite promising. And you also mentioned cardiac devices earlier, and we got a few questions around foreign objects and whether phage therapy could be used for that. So specifically mesh and also indwelling catheters. Have you seen case studies where phage therapy might be beneficial there?
Yes. So one of the issues with devices, whether it's mesh or a urinary catheter or cardiac device, when they get infected, it's usually due to biofilms or sort of a slime layer, on that device that consists of the bacteria, but also a lot of extraneous material, which makes antibiotic penetration or antibiotic activity very minimal. And that's part of the reason why we can't resolve those infections, and we, exchange out a pacemaker or take out the infected catheter. So what's really exciting about bacteriophages, there are a number of them, and perhaps Austen, Sabrina can add in after me, that have actually excellent biofilm penetration and can degrade biofilms very well. And so I think that is actually really exciting. So we have used phages, with such in vitro activity for a variety of different device infections. Not all of them have been successful. So we're still trying to learn how to best do this. But yes, there have been cases, with prosthetic joint infection or cardiac device infection that we have used phages that specifically degrade biofilm along with synergistic or additive antibiotics to resolve the infection without removing the device.
Yeah, I think our common wisdom or logic here is that the closer you can get to the infection with phage, the better the outcome you're more likely to get. So when it comes to prosthetic joint infections or any kind of device infection, if you could instill a dose or more of phage at that site, that is preferred. And as I think another option that was mentioned was gauze, right? If you have a way to keep the phage in place on site with gauze, so that it's not cleared out by the patient as quickly, and can keep kind of dosing over time as well, that would certainly be best.
No, I just want to add, that's just like one of the coolest parts about phage is that, they make these enzymes that break down these biofilms, it's a perfect compatibility with antibiotics that can't penetrate the biofilm.
Right, that was exactly one of the questions we got. Would phages be useful where there are biofilms in the bladder or where the infection is within the bladder wall, especially because antibiotics are just ineffective in those scenarios? And it sounds like it is possible if you choose the right kind of phage. There were some other questions around the antibiotics too. You said that you often use them in combination. Is there a particular antibiotic that is usually used in this kind of scenario, or will that depend again on what bacteria is found?
I think it very much depends on what bacteria is found. And I will say for some of my recent infections, I've recently started treating without concomitant antibiotics, mainly because we were trying to eradicate colonization as a source of recurrence, rather than treat, an acutely ill person, in which case, antibiotics would be indicated. But yes, so we've certainly, when we're treating people that are sick, and again, I think Austen, Sabrina can add in, it's pretty standard now for most places to actually look for synergy and sort of do testing to assess synergy between, particular antibiotic. And there's no, I think, one that's used specifically. It depends on what the organism is and what would be the best antibiotic for that, along with phage. And if there's no synergy, at least, there's no antagonism.
Yeah, so we found in our lab that, synergy and antagonism actually could depend not only on the phage, but the bacteria and the antibiotic. And so it's really interesting in that, the way that we prepare phages is that we test all this prior to a patient getting treatment. So it is real personalized therapy. You know that the phage works well with the antibiotic, and they both work well to combat that bacteria. And so we think, at least at Taylor, that it's very important to test for this prior to treatment of a patient. Research, though, out there on what's happening in vivo is still kind of, we don't know yet if we actually do see this synergy or antagonism inside of the actual patient going through an infection. But so far, all the in vitro data tells us that, yes, we can actually pair phages with antibiotics and they can work better together.
Great, that's really interesting. People also asked if phages could be used as a preventative rather than treatment in the same way that antibiotics can.
Yes, I think that's really exciting. So I have actually treated a few patients like that. So I'm a transplant physician, so most of the people that I see are usually very immunocompromised and tend to have recurrent infections. So one patient in particular we did write up was a lung transplant that had recurrent pneumonias from a highly drug-resistant Pseudomonas. And the first two times, we did treat successfully with phage and antibiotic combinations. But thereafter, to prevent further recurrences, I actually just had him on phage alone for a couple of months, and there was no recurrence of infection during that time, which allowed the patient to improve. And similarly, as I mentioned earlier, I think there are certain kinds of infections, and recurrent urinary tract infection is one of them, in which that we know there is a reservoir of infection or reservoir of the bacteria, which leads to these recurrent cycles of infection. And that reservoir may be within the GI tract as part of the microbiome of that patient, or it may be, as you mentioned, the biofilm within the bladder. So I find those cases really interesting in terms of maybe we can use phage alone to sort of alter that microbiome, to very selectively target out the pathogen that's living, in the GI tract. And when we do that, will that then allow healthy bacteria to repopulate the GI tract? And I've done that actually in a couple of patients. And it seems, and again, it's just, these are just cases, right? This is not a clinical study. But I think it's promising to try and, selectively target and change that microbiome and, potentially then reduce recurrences or prevent recurrences of infection altogether.
Do you need to then identify where that reservoir might be in order to know where you should deliver the phage?
Yes, for sure. And again, sometimes that's not always clear. It may be that a patient has several reservoirs. So again, in the sort of kidney transplant setting, these patients have recurrent urine infections and over time actually lose their kidney function. The reservoir tends to be the GI tract, but at times patients could have, a stitch that got infected, or they have a stone in that urinary system that acts as that nidus of infection. So I think, at times they may not just be one within the lab, it's very easy to have just one, source, but in people at times there may be a few. And I think that's sort of why I like intravenous phage. I feel like it will get to these various sources and potentially have a better outcome than if I just did, say an enema of phage targeting the GI tract alone.
Okay. If phage therapy is going to work for someone, how quickly might their symptoms improve?
So part of it depends on what we're treating and what the symptoms are. So I think, for cystic fibrosis patients with, say, a drug-resistant Pseudomonas that are having, symptoms of a pneumonia, so cough or shortness of breath, or just a lot of sputum production, that can start improving within a few days to a week. And that's true if we're using antibiotics that are treating the patient or phages. For urinary tract infections, we've used phage really in the setting of people that have long, either intractable infections or recurrences. So in that too, I think it takes a few weeks to see effect. For cardiac device infections, usually you'll see effect also within those first few days to a week when patients start feeling better.
Yeah, that's quite fast. And what's the scenario when phage might reduce one organism only to give rise to another? Are there protocols to then switch to a new phage or something else that you might do there?
Yes. So again, I think, it's hard to talk in generalities. So again, it depends on the sort of infection we're treating. So the respiratory tract, for example, is never sterile, right? The GI tract is never sterile. And we know there's a host of other bacteria within there. So when we are targeting, again, for CF, usually over time, they have a variety of different Pseudomonas isolates because of the antibiotic pressures, they've received over their lifetime. So phages are very targeted and very selective. And it is possible that we are selecting just for a very specific isolate, and it may allow other, either MDR or non-MDR Pseudomonas to grow over and, potentially lead to infectious symptoms as well. So I think it's hard to predict, at least at the moment in patients. But yes, so when I start treating patients, especially those with gram-negative infections, at sites that tend to have probably other gram-negatives there as well, that there's a potential that symptoms can get worse, or patients can get a new pneumonia, for example, from a different organism. It's not common, but I think it's something we should think about until that issue, again, is sort of solved in a more systematic manner in trials.
And what happens when someone's symptoms don't improve? How do you adjust then?
So, for some of the patients that I've treated, especially initially when we're treating with long courses, we did change phages over time. And part of that was because as we treated and got rid of, very targeted or selected Pseudomonas or E. coli, we had other isolates that popped up that were resistant or not so susceptible to phage. And so we changed our phage therapy to target them better. And we've done that with cardiac device infections as well. But I think Austen was going to add on.
Yeah, again, I was going to say that we have had a number of patients that have been treated with our cocktails in these past couple of years that have had this happen, where the initial infection and bacteria they were suffering from was cleared, but then some other bug came and took its place. And this speaks to a point that I heard Saima made previously, but is known in the field, right? That phages and phage therapy are not a panacea cure-all to every kind of bacterial infection that you may have. But what it can offer patients is a step towards the right path towards being better. And I think part of what Saima was saying here is that, say your initial infection was cleared, but some other bug came by that was not as virulent, not as infectious towards the patient, and not as resistant to the antibiotic drugs that we have on the shelf. Well, even though the patient may still be suffering at that time, that is a good step, because we now have brought some options and tools back on to to the table in order to help get these patients moving forward.
This question also might be for you, Austen. What happens when you identify that the infection is polymicrobial from the start? How do you know which organism to treat, or organisms if you decide to treat multiple?
Yeah, great question. And as the audience might get tired of hearing, it really just depends on the patient and case. What we really want to know and look for is the causative agent of disease and infection, right? What is the main culprit that is causing most of the problems for the patient? So if we can narrow in on that, that is what we would target with phage. And even better if that bug is clonal, meaning that it is practically the same strain of bacteria that has been sampled from the patient over time. That means that from our point of view, we have a very stable target that we can then treat with phage. You don't want to do a lot of work trying to get phage for this bug and that bug and all sorts of things. Again, just for a simple practical reason that all those phages might not function, in harmony when you're trying to concentrate them down on a cocktail. You want to try to keep things as simple as possible when it comes to treating with phage.
Okay.
I'm going to add on to that. At times, for some polymicrobial infections, it may be, and this is common, that the one particular organism is the one that's highly drug resistant, but some of the other organisms are actually pretty susceptible to other antibiotics. So again, I think using a combination of antibiotic and phage can actually effectively treat a polymicrobial infection as well.
Okay. A lot of the patients in our community do get results like that, where there are multiple organisms. So it's good to know what the approach would be there.
Yeah, I'm going to add one more thing to that. So urinary tract infections in particular, though, tend to be monomicrobial. And at times when urine cultures do have a variety of different organisms, some of them can be contaminants as well. So, we've had patients that reach out to us with staphylococcal epidermitis, for example. That's not a typical uropathogen. And it's not something that I would sort of target with phage therapy. So I think part of getting results on a culture is also to understand, well, which among these is actually cause urine infections, because that's probably not true for all the organisms you get from a urine culture.
That brings us to the question we received about culture. If you do need to use standard culture for phage therapy, what do you do for patients like many in our community who are generally culture negative because of biofilms or embedded infection?
So unfortunately, we get a lot of requests like that, or people that underwent, sequencing of urine, for example, and it comes up with matches against a variety of different organisms. So at the moment, and again, I'll have Austen and Sabrina pitch in, at the moment, phage is very personalized. So we would use it when we have an organism that we can actually test in vitro or in the lab to see if the phage that we have will kill that bug. So if we don't have an organism on culture, we're really unable to do that. And we're unable to really target the phage either. So for those patients currently, we don't treat those because we don't know what to treat.
Do you use expanded culture in that process or standard?
So generally standard. I mean, standard culture is what's, standard of care at microbiology labs sort of all over the country. And expanded culture tends to be in a research setting. So I think that's something that can be looked at, when doing clinical trials. But for regular clinical care, we don't do that. And I think it would be difficult really to pursue that.
You really need an active host in hand in lab in order to be able to figure out whether you have virulent phages against that strain, rather phages that are capable of infecting and lysing that strain. The bold future, maybe that's sort of where this question is trying to edge and lead towards, is are we going to be able to have ways to predict whether the patient strain is susceptible to the phage without having that actual strain in lab? We certainly hope work for that future. We think we can build tools that can get us closer there, but we just aren't there yet.
Part of that is also sort of developing these sort of vast libraries, and also, you know, developing kind of superphages, so phages that have wide host range against a particular organism, or being able to genetically identify that if you have, you know, X, Y, Z mutations or what have you on a bacteria, it will predict that this phage will work on it.
There are groups that are working on this, and we're of course building a larger library here. And actually, one of our largest libraries is against E. coli, so E. coli phages. And so, yeah, the hope is to learn, you know, if we could actually match a phage to a bacteria just by a sequence. And then in the future, also, we see that maybe we could develop phages without the bacteria. So this is something that other groups are working on as well, and we hope to work on too. And so if you think about it, not only do you need a culture to isolate the bacteria so you can test the phage, but you need a bacteria to grow the phage, because we grow it up to high titer so that we can purify it and then treat a patient. And so that's also something that you need to consider. There are bacterial strains that you could probably use that aren't the patient's strain to purify, but sometimes these phages are so specific that you may need to use the patient's strain in order to purify. So there's technological innovation that we need first in the beginning part to match the phage, and then more innovation to purify and to develop the phage without the bacteria. But currently we're using the regular culture standards.